Thank you also for the kind introduction. And as Naomi already said, I will talk about exercise after kidney transplantation, since this is a moving field. This introduction is probably not necessary for this audience, but I'm just showing it because it will be the stepping stone for my presentation. So we know that physical activity, we know the definition that the skeletal muscles have to do energy expenditure. We know that the FIT principle is very important in the physical activity definition. So FIT means frequency, intensity, time, and type. Then exercise training is a part of physical activity. And it's planned, structured, and repetitive with a specific goal. And this goal could be the intention to improve or to maintain physical fitness. And we have different types here of exercise training: aerobic or cardiovascular training, strength training or resistance training, flexibility, and balance. And then we come to another term, which is physical fitness, which is the ability to perform physical activity dependent on health or skill-related attributes like cardiorespiratory fitness, muscle strength, flexibility. And physical fitness is usually measured with the peak oxygen consumption or with, for example, a 6-minute walking test. If we are talking about intensity, then it's important to know that with increasing intensity, we got an increasing heart rate, breathing frequency, and also sweating. And this we can measure in an objective and a subjective way, as you probably all know. So we have the MET score and the rate of perceived exertion score. This is just as a very short introduction. So now we come into kidney disease, and we already saw it in the previous presentations. Patients with kidney disease, they have a severe disease, and both physical activity and physical fitness is very low, as we already saw in the presentation of Evelyn with the publication of Celle. This is true for patients with chronic kidney disease, but it's also true after transplantation. We know also that in this patient group, both physical activity and physical fitness are predictors of mortality. So the better both physical activity and physical fitness, the better the survival rates. Background of these mechanisms, the lower physical fitness can be primary organ dysfunction, for example, heart failure, like we saw in the previous presentation, or arterial function. And this is because of this disturbant effect of uremic toxins, which result in fatigue, anemia, muscle dysfunction, and malnutrition. So it is really a very complex puzzle, but we know, or we believe, that exercise training or exercise therapy can improve all these elements. So what happens in transplant candidates? We know physical activity and physical fitness is both very low. So can we, with exercise training, can we improve both these items? And just to show you, Belgium is part of the Eurotransplant group, and yearly this Eurotransplant group performs about 30,000 transplantations a year, of which 20,000 are kidney transplantations. So it's the main organ to be transplanted in Eurotransplant, and I believe across Europe and across the world also. If exercise training would prove that physical fitness could improve, would we then also see better outcomes before and after transplantation? And would we see a better quality of life? Well, the best to answer this question is to go to the evidence, and this is a systematic review, a meta-analysis, and in dialysis patients, and there we see that every type of training, it doesn't matter which type of training, improves the peak oxygen consumption, muscle strength, and quality of life in dialysis patients. It was 21 trials for the peak oxygen consumption, and 6 trials for the quality of life. What happens after transplantation? Well, we do have some data about mortality, survival, and physical function. And what we see here is that physical function before transplantation is a determinant of survival after transplantation, which is very important, of course. And this means that every dialysis patient should already start exercise training before getting transplanted. And this nice study showed that about 11% fewer deaths would occur if kidney transplant recipients with the lowest functional status experienced modest improvements in function. And it's only modest improvement which is required to see this huge impact on survival and mortality. What about prehabilitation? So again, what about training in dialysis patients as a preparation for kidney transplantation? And there we see that supervised weekly sessions of 40 minutes during 2 months with home-based exercises improves indeed physical activity. It's not surprisingly, of course. Intriguingly, the duration of hospitalization for transplantation was shorter in the prehabilitation group, but we have to say here that it was a very small piloted study, so we really can't draw any conclusion on this. But it's reassuring that we can see a positive effect also after transplantation. So what's the evidence from randomized controlled trials in transplant recipients? So we already saw some evidence in dialysis. What's the evidence in transplant recipients? And there we go to the SUM outcomes, which is the standardized outcomes in nephrology about transplantation. And what you see here in blue is the outcomes which are very important as judged by patients and clinicians for transplant patients. It's mortality, cardiovascular disease, cancer, infection, graft health, life participations. Now we know that mortality in kidney transplant recipient is higher, and this is due to immunosuppressive therapy, comorbidities, inactive lifestyle, etc. Now, what you see in green, with the green circle around it, is that we have very strong evidence that exercise training improves, for example, physical fitness and physical functioning, and also quality of life. So we also know this in transplant recipients. And the good news is that, for example, quality of life is correlated with life participations. When patients are feeling well, they get back to a normal life sooner or better. The same is true for physical fitness and physical functioning. So they are correlated with both mortality, cardiovascular disease, but maybe also with cancer, infection, and graft health. Bone health is also positively influenced by exercise training. We do know in transplant candidates that exercise training is safe, and reported in the literature are cardiovascular events, graft health, and injuries. We also know that cardiovascular function improves when a patient after kidney transplantation does some exercise. With respect to arterial stiffness and cardiac autonomic function, the evidence is not very convincing for blood pressure or for other cardiovascular risk factors like body composition, diabetes, hypercholesteremia, and inflammation, but at least it's safe. And whether this also results in an increased survival is not known yet. So there are some remaining questions, of course, in this patient population. And one of them is, what's the role of exercise intensity? So does it matter how intense patients train? It's often small studies with lack of power which are conducted. And what about implementation of physical activity? So it means, what about exercising, about being physically active on the longer term? And last year we were very lucky to obtain funding for the Phoenix project by the Belgian Institute of Sciences for the Phoenix project. So it's a home-based physical rehabilitation in abdominal organ transplant recipients. How intense should exercise be? And in what follows, I will just shortly introduce you to the protocol. As you can see, it's a collaboration between our university, UZ Leuven, and the University of Ghent, which is also a Belgian city. The aims of this randomized controlled trials is to evaluate the effects of a home-based training program, which is personalized, followed by an individualized physical activity program. So we do both exercise training and physical activity in de novo kidney transplant recipients. Primary outcome is physical fitness. Secondary outcomes are cardiovascular health, safety, cost effectiveness, quality of life, and also for physical activity implementation potential. Also gut microbiome, which is being highly studied nowadays in dialysis patients and in kidney patients, is one of our outcomes, since we hypothesize that exercise training might have a beneficial effect also on the diversity of the gut microbiome, with this having potential effects on the longer term, and with this also maybe have predictive effects of being a responder or non-responder to training. A second aim of the Phoenix project is to evaluate the role of training intensity. I will just show you shortly the study design. We will include about 149 kidney transplant recipients, and we will have 3 groups, so we will have about 50 patients per group. One group will be the low intensity training, the moderate intensity training group, and the moderate and high intensity training group. So 3 groups, all training. We doubted a little bit about the usual care group, of course, but in Belgium, since we do have 18 sessions reimbursed, it's quite difficult to tell our patients not to do any exercise training. So about 6 weeks after transplantation, we start to speak about the study. We will include both men and women, and as I previously said, it's a collaboration between Ghent and UZ Leuven. Patients with a positive cardiopulmonary exercise test, or positive, it means aberrant, will not be included, will be excluded. With muscle injuries also, and no access to a smartphone or computer will be an exclusion criterion too. We will inform the kidney transplant candidates, as said, very early in person with a leaflet, and we will recruit them actually only 6 weeks after their actual transplantation. Patients willing to participate will be included after the cardiopulmonary exercise testing is done and after a formal screening by a cardiologist for safety reasons. Why we do this like this? Well, we know that 100% reach would be impossible, and we are also interested in why patients would not consent to participate. So we will also collect sociodemographics and medical history of those patients. We will gather information about barriers and motivators to physical activity, and we will perform semi-structured interviews on the reason why not willing to participate. This is the study design again. And I will just go through the phases, the different phases of the study. So in the low intensity training group, of course, we do have the low intensities, which is just flexibility training and balance training. Moderate intensity training is quite higher. It's all home-based on a cyclometer at home. And what is different about the third group is that 3 months moderate intensity training will be followed by 3 months high intensity training. The delivery method will be the delivery of the intervention will be in person. So we have a PhD candidate, which is a physiotherapist, and she will supervise at least 18 sessions for all patients. She will do this in preference in our hospital, but it might be also possible that part of them would be via teleconference. And what's also important is that we will use an existing training platform, which is called Coachbox, to follow the adherence to the training prescriptions, and they also have to have a diary, of course. Then for the next part, the physical activity program, then there it's important to say that it's co-designed together with the patient. For this we work together with Sabina de Geest in Basel, since she is an implementation scientist, and it's also important there to use motivational interviewing techniques and to have the necessary follow-up contacts. Different time points, we will of course assess the different outcome parameters, and we will start the first baseline data is 3 months after transplantation, then after the first 3 months of training, then another 3 months of training, and then 1 year after transplantation. We have the fourth time point, and it's important to note that at 3 months and at 12 months, we also have protocol biopsy, so we'll also have information about the kidney graft. And then after 2 years, after transplantation, we will have the final analysis. So this is just an overview again of the different outcome parameters: physical fitness as measured by cardiorespiratory fitness, 6-minute walking test and the CPET, muscle fitness, motor fitness and body morphology. Cardiovascular health, there we will measure both FMD for endothelial function, but also the microvascular function as measured with the dynamic vessel analysis of the retinal arteries. We will measure blood markers, uremic toxins, arterial stiffness in vivo, and last but not least, of course, we will monitor safety and gut microbiome composition. We do have also a questionnaire about participation in working life, activities of daily living, questionnaires about fatigue and quality of life. Of course, we will have to monitor physical activity with the device Actigraph, and we will certainly also monitor motivators and barriers according to plan. For implementation, we do have different outcomes parameters. I just give you some examples: the acceptability of the intervention, the training fidelity, and the attrition. Of course, I would also like to take the opportunity to thank our collaborators here, which is a truly multidisciplinary research consortium, and nephrologists couldn't do this alone without the support and the guidance of physiotherapists and basic scientists. Thank you.
Thank you, Dr. Craenenbroeck, for your excellent presentation. And now I invite the two commentators for their position. Firstly, I ask Dr. Vasilis Diakopoulos, Professor of Nephrology